So this session is about the fact that when people get physically injured on the job, it is often the psychological injury that stays with them the most. So I want to talk about what we know about the mental health impacts of the work. I'm going to focus very heavily on the EMS side of fire for fire-based EMS systems, because in my research, that's what's driving most of the burnout. But everything that I say and the intervention, the organizational policy intervention that I describe is legitimate for just single role firefighters as well, okay? It's just that we're focusing on where the need is greatest. So, and please, since we're an intimate group, feel free to interrupt me at any time. So I just wanted to disclaim or disclose that the following slides have graphic images. So does anybody know who Ben Vernon is from San Diego Fire Rescue? Okay. So Ben was stabbed by a bystander at an EMS run on the trolley tracks in his local in San Diego. They had actually gone to a medical emergency for a drunk guy, and this was a bystander just there. And this bystander kind of came in and out of the story and ultimately engaged verbally with the crew, which included not only, in San Diego Fire Rescue, everyone is a firefighter paramedic, and there are 4 to 5 guys on a piece, right? And then you had the San Diego Transit Police, and then there were like maybe 12 people here, and this went down. So this is the gentleman that Ben calls Stabby, stabbing him. He got stabbed 3 times and had a collapsed lung. And so this is his partner so this is Ben, and this is his partner. His partner actually stepped in and was able to subdue the bystander. And Ben, so he was hospitalized, he was near death, but what he talks about, and we are part of a team of speakers on the issue of violence in the fire service, is that he had suicidal ideation, he had PTSD, he had nightmares. The biggest part of his injury was not the physical part, it was the mental part. And so I think in the fire service, when we think about initiative number 7 of NLSI, which is, do something about every line of duty death, near miss, and injury, we don't really think about the psychological injury, right? Which can happen from a traumatic event like this or from the BS runs, right? Your shoe runs, same shit, different day, with people who just aren't connected to social services, who take a lot of your time, who are your BLS calls, right? So all that accumulated exposure can weigh on your mind and cause a mental injury, right? So that's the first one. Anybody know Kelly Adams in Detroit? Anyone hear her story? So Kelly is a firefighter in Detroit, and they went to a run for a woman with an injured ankle. It was a homeless shelter. They'd been there many times before, and her boyfriend attacked Kelly's partner, who started to bleed out from defensive wounds, and she took a stool from the ambulance and started to try to get the assailant. And she then was also stabbed. And this is her face, and it's important because these are very extreme physical injuries, and this is what happened. She is still paralyzed in her face. She's had millions of dollars in plastic surgery. But what she talks about is the post-traumatic stress that she had as a result. And people seem to recover from their physical wounds, but we don't seem to have a good way in the fire service to help them with the psychological ones. So Kelly, Ben, and I are a team. We go out and talk about this issue of violence on the job, workplace violence, it's often called. It's a little bit of a misnomer because you're in the fire service, you're mobile, you're not in a bricks and mortar environment like the hospital, but we consider this workplace violence. So that's what we talk about. The other thing that often happens with these types of assault-related injuries that have this mental component is the fire department doesn't know what to do. And so in Kelly's case in Detroit, they wanted her to resign her position because she was on disability for a long period of time. So they gave her an award, and she got all the stars and things like that, but at the end of the day, they just really didn't know what to do with her because she was so traumatized. And this is a really important part of the intervention that I'm going to describe to you, the SAVER systems level checklist and model policies, because your organization needs to be prepared for not only physical injury, but the sequelae, right? And that's it. And and the union as well. The union was definitely not stepping up after the initial. So these psychological injuries, they come up sometimes immediately after a physical injury, and sometimes it takes a long time. So the department really has to have a plan for how to check in and follow up with these folks over time. So you saw this in my last presentation, so I don't know why my PowerPoint is doing that, but in the First Center portfolio, and I share this slide, so if you're on our website, you know where to go. We have a particular area called stress and violence to fire-based EMS responders, or SAVER, right? And this is to bring epidemiology and organizational science to policy and training so that fire departments can premeditate the fact that these types of physical and psychological injuries are going to happen to their personnel and adopt policies and train policies so that they have the backs of their EMS responders when they're in the field. So this is a very different type of strategy than asking the workers to have responsibility for their injury, which is traditionally how we do occupational safety and health in the United States. We blame the worker. Why weren't you more careful? Why didn't you do something? And this is about organizations taking responsibility for these known outcomes. And so a lot of this work has been funded by FEMA. We had an R&D grant to build this checklist and intervention. And we have a contract with the International Association of Firefighters to develop an online training program for workplace violence in the fire service that's very similar to the Fireground Survival Course, if you've taken that. So this will be called like the EMS Survival Course. I'm not sure yet. It's a name in progress. Oops. Okay, and so just like my disclaimer last time, data, right? Data are okay. Data are our friend. Data are good without data. So I'm going to show you data. And that's important. So I just want to ground this in some important data. So this comes from NFPA, and the blue line is the increase in the number of EMS calls in the United States starting in 1980 going to 2016. It's a 350% increase. The red line is a 55% decrease in that same interval for fire runs. The issue here is that we have not appropriately resourced EMS to handle a 350% increase. And it just goes up and up every year. So the demand on this part of our workforce is significant. And we're not prepared for it. So that's going to have mental repercussions. And it's always interesting to me as a scientist because I eat data first. Right? I don't really think about the history of the fire service, even though I know it. I just look at the data. So this is from FEMA that tells us on average that EMS is 60% of what every fire department does. In Philly, it's 87%. We do 1,000 EMS runs a day. It is 87% of our call volume. In San Diego, it's 75% of their call volume. In Dallas, it's about 80% of their call volume. So we're not staffing. First of all, what's the bread and butter for a lot of fire departments and keeps us operating? And we're not thinking about, do we have enough ambulances? Do we have enough paramedics, EMTs? Do we have anything that gives these people some rest and recovery? And it is what we have found in our research is that it's absolutely not there, which is why we created an intervention to particularly address this. I showed you focus in the last session, and this is just an illustration of engagement with work, which if it's green, it's good, and if it's red and bad, this is just this is mock data from an amalgamation of fire departments, but we know from the focus survey that firefighters are less engaged with the EMS side of their work than the fire side of their work. You could have told me that, but I just have the data to tell you that, right? I just have your backs on that. So you go to city council, you say our people aren't engaged in work, and they'll say, well, how do you know that? And then you can show them the data for your department or the national data that we have. We also know from focus that the EMS side is what's driving burnout in the fire service, but fire has its own burnout. So I want to be really clear. The fire side of your work is not without its mental impact, right? So, but EMS is really what drives that. again, nothing that I do is rocket science, but it gives you the evidence behind what you've been saying to me for about 40 years. So when we've looked at the issue of workplace violence, here's some of the things we hear from firefighters. I've been kicked, punched, bitten, spit on, verbally abused, you name it, I've had it all. And we also do a lot of policy work at the First Center. So we have studied what states have felonious assault statutes for first responders. We are also in the process of releasing a paper on PTSD for mental health and other presumptive laws that exist. And that's going to be a fascinating read for y'all, and we'll make sure that that gets sent to the organization for dissemination, and it'll be on our website. But so in the state, this particular study here called Felony Assault Should Stick is what I call the other Philadelphia story, if you're familiar with the movie. Anybody old? You're not really that old, but okay, good, yeah, okay. So, but this is the other Philadelphia story in that firefighters, paramedics, and EMTs are getting assaulted at really concerning rates in Philadelphia, and in Pennsylvania, we have a statute that says, don't worry, if somebody assaults you on the job, they're going to jail for 5 years. So we actually worked with the district attorney's office in Philadelphia to find out actually what happens, because when we talked to firefighters, they said this. And I went to court, and this is where it's disheartening, because that's supposed to be a felony assault, and I'm wasting my time going to court 2 and 3 times. I knew there was no confidence in the system. I mean, you shouldn't be able to do that to someone who's trying to help you. Felony assault should stick. So you can also see, my friends, that if you participate in research with me and you tell me things, you become the title of one of the papers. So if that blows your skirt up there you go. So yeah, please, yeah.
This is rough. Is there any chance that they'll change that where we can dig a little deeper? Like, of those 64%, what's ALS? What's BLS? What's no treatment?
Yeah. No, so one of the other things we do at the First Center is we do injury data linkage. So for example, in the city of Philadelphia, I have 15 years of run data, 15 years of first reports of injury, 15 years of workers' comp records, 15 years of hospitalization data. I can tell you all that for the city of Philadelphia. So if you share your data with me, I can do that for you. I don't know what it looks like at the national level, how they can break that down, right? But we know in Philadelphia, 90% of our EMS runs are BLS. 70% of them go out as ALS, but 90% of them are BLS, right? So yeah. Any other questions? I mean, stop. This is our intimate meeting, so please.
So I was trying to find this on my phone. You just said those stats. What were the stats you just said about runs being dispatched as ALS but being BLS?
So in Philly, right? 70% of our EMS runs go out as ALS, but 90% of them are BLS. Okay, so that once you know you have reported as found to be, right? So when you look at the run report, then you can see what it was found to be, and so we go back and we recode that, right? So we can determine, and the department does as well. Like, you know, somebody calls and they say, I have chest pain, that's ALS. You get there, they broke their toe 3 days ago, right? People know how to work the system, right? Yeah, but that's very easily done in the CAD data, very easy. And in the patient care report, PCR. Okay. So we have done a lot of research on violence against first responders. And so one of the things that I did, my very first job with the fire service was with the IAFC and analyzing their near-miss data. And do you know about the National Firefighter Near-Miss Reporting System? Are you using it? It's definitely taken a hit over time, but there was a time it had really robust data, and I got to analyze that data. And when I looked just at EMS runs, EMS near misses reported to the system, we learned that assault was the #1 cause of injury on an EMS run. The second was motor vehicle crash. All these papers are on our website, so if you're interested, like I said, they're all there for you. But we also found, when we looked at assaults, we found the 3 conditions of people who assault firefighters. What do you think they are? Drugs. Yep, what else? Drug and alcohol, right, that's one. Mental health, right, you know, whether it's a diagnosis or they're just expressing. What's the other? grief-stricken? Yeah, it's the underlying condition of the patient. So they could be hypoglycemic, they could be senile, they could be autistic. Their underlying condition can make them combative. If you have someone who has an opioid overdose and you give them Narcan, you've just ruined their day, right? And so when you wake them up, they're going to be pretty pissed, right? So these are the things, these are the major, and we're talking more about patients in these data. They're bystanders, like Ben's situation was a bystander who was just kind of off his rocker and thought he had a job to play. And then there were 12 guys standing around doing, I don't know what. But that's what we're learning a bit about people who assault first responders and kind of what their profile is, right? We've also learned, again, from the Philadelphia story, that paramedics had a 14-fold higher odds of getting assaulted than firefighters, even though firefighters in Philly do first response. And so our hypothesis here is that the paramedics are doing the intimate work of patient care. They're in the back of the box with the patient when somebody else is driving, and that's when a lot of the stuff goes down. So most of the assaults are occurring in the ambulance. Right, again, this isn't, not rocket science, but it's good to have that data. As a scientist, to have a 14-fold odds ratio, I will never see again in my life, most likely. That is a very high odds ratio, and a lot of people were like, you need to rerun that data. And we did 2-3 times to make sure it was right. But that's really wicked. And then we did, USFA and IAFF hired us to do a literature review. Right? But what we did, and to give us good estimates on what was the prevalence of violence to firefighters, and what we did is we didn't just look at the peer-reviewed literature. We looked at your literature. We looked at GEMS. We looked at EMS Manager. We looked at all of the industrial trade publications over 40 years. And you have been talking about this for 40 years. Science talked about it in the 90s. That's when science first documented this issue to you. But you guys have known about this for a long time. So we published a literature review that talks about what the industrial literature and the peer literature said. Right? So it's all on our website as well. And what we found in the literature is that for the first time injury, the lifetime prevalence, the career prevalence of assault for a firefighter is between 57 and 93%. Pretty wide interval, but this is very high as well. So basically, everyone is experiencing this. It's what we learned in the felony assault study is that firefighters have internalized the belief that being assaulted is an expected part of the job. We have also learned that the judiciary believes that as well. And that's a problem. And so at the end of that felony assault paper, we have 3 recommendations, and one of them is to educate the local municipal court judges and attorneys general about that this is not in the job description of a firefighter, paramedic, or EMT to be assaulted on the job, because they are saying that's what you signed up for, right? And it's absolutely not true. So we need to do a better job about that. I want to present some really new data. When the pandemic happened, we got a very small amount of money to do a rapid mental health assessment of the United States Fire Service because we were concerned that this was going to knock it off the charts in terms of your mental health. So this is the RAPID study, or the COVID Rapid Mental Health Assessment. And I'm not going to go through every slide, but I'm just going to show you some things. So we had our board of people who sent out a quick message to all of our participating fire departments in our research to get on board with this. And in May of 2020, right as states were starting to shut down, we started assessing on a monthly basis a very large mental health panel, a survey, Focus Plus. We took Focus and we added a shit ton of mental health metrics to it, that all validated, and we gave it to 20 fire departments around the United States, and every month they had to take this survey. They hate me now. But they did it. And that gives us some very interesting information that I want to share with you. So the red departments are departments that were participating in our SAVOR study, the stress and violence study. So those were already on board. The other blue states are states that had done a focus assessment recently. So only departments that had done a focus assessment in the 6 months before states started shutting down were eligible to be included. So we didn't open it up to everyone because we needed good baseline data. So that's who participated. These are career, volunteer, combo, the whole mix. That's what we do at the First Center. And we gave them monthly reports on their data. And I just want to, and I just want to share some data. Please don't take any screenshots because this isn't published and it's kind of right off the charts. So I just want to be mindful of that it hasn't been peer reviewed yet. So a couple things that we asked them is, how is COVID affecting you, right? And I know this may be hard to see, but the top 5 across the sample were, my number 1 fear is fear of transmitting COVID-19 to family and friends. Number 2 is change in eating patterns and lack of appetite, a sign of stress. Change in sleeping patterns, lack of sleep, another sign of stress. Required by work to quarantine or self-isolate, another source of stress because it removes you from your social support. And then lack of access to PPE. Now these data are from large metros, so they had some PPE issues, whereas some of our other departments that were smaller had some more agility. So it looks different depending on the size of the department. We also asked about exposures. So we expected that they would be exposed to infectious agents. It's a pandemic, right? We would expect, because they were still doing fire suppression, that they would have this. But we also threw in this question, because our hypothesis was, if the world has gone crazy, our previous research tells us they're going to take it out on the first responders. And in the large metros, that's absolutely what we saw. We did not see this in the small departments, in rural departments. That's why nobody wants to come to the big city. Okay, a lot of data, but I'm going to walk you through it. Here's what we found in general. So we only had the resources to do this for 6 months. Every month we sent a survey and they filled it out, and they had to get that 60% response rate. We found that over the course of those 6 months, as the pandemic was getting started, across the country, leadership communication went in the toilet, and supervisor sense giving, like, why are we doing this? Why do we have to wear this PPE? Why are we making all these changes? That these things started to atrophy during the pandemic. Not a surprise, but we were able to measure it. And this is the first time we have safety climate data on a monthly basis. We never expected to do this. Like when we do your regular focus assessment, it's like maybe once a year, once every 2 years, whatever you want to do. We also saw morale or job satisfaction go down. We saw engagement on the EMS side of the work go down. We didn't see engagement in fire go down, right? So that's, again, you're running more EMS, or you're not running more EMS, but you're spending more time on task, right? We saw participation in decision-making go down. It wasn't that great to begin with across all these fire departments. This is a new metric that we're including in the future focus surveys in 3.0 because it became a really important one. So there's no sense of shared governance in the fire service. There's no, it's me telling you, shut up, follow me, and you'll be okay. But what we're learning with new generations in the fire service is we need to answer the why. We need to explain to them why we're making decisions that we're doing, and that has direct translation into their satisfaction and mental well-being. So decision-making has become very important. We also saw resilience, the ability to recover, go down during this time in this sample. And then finally, don't worry about the DPs and the EEs. These are all different aspects of burnout. Emotional exhaustion is the EE. That's the immediate. I went on this run, I'm just... Depersonalization is, I am so effing tired of going to someone's bullshit run on EMS. That's a long-term effect. And what we see is that depersonalization and emotional exhaustion on EMS and depersonalization, that long-term, went up on both EMS and fire, and emotional exhaustion on EMS went up during these 6 months. Right? None of this is surprising, but if these fire departments hadn't done this really huge lift for us, we wouldn't be able to talk about that. Now, what I hear, especially from departments like Prescott and folks out west, is that the pandemic came at them later. And they're like, Jen, we're getting slammed now, and it's January, and you're stopping the assessment. So again, that's part of the problem of research when you don't have funding. Like, your funding only goes so far. We also saw, this is a different metric, but it's percent high anxiety, percent of people who scored as high anxiety in the department. And so these don't have up and down arrows, but these are the averages across the sample. 38% of respondents to the survey had a high anxiety score, and 32% had a high depression score. So we didn't have previous baseline data on the fire service to know what it was. Was it 20? Was it 50? Et cetera. But these are things that we're now including in focus because they've become so important, as I'll show you on the next slides. Any questions or comments at this point? So what I want to do is just take you a little deeper. Can I take you a little deeper in the data? Okay. So I want to show you what this looks like over time. So you'll remember, I hope you remember because it hasn't been that long, that FOCUS has management commitment to safety and supervisor support for safety. So management commitment is this blue line and supervisor support is that orange line, right? There's a big difference between the two, right? And you can see it in these departments. This leadership communication started almost at 60 and ended up around 55. This is a statistically significant decline during this period of time. So it doesn't look like a big decline, but it's in organizational sciences, it's a big decline, right? So you're just gonna have to trust me on that. So we see that, and we also see that supervisor sense giving, which is this yellow line, again, it's high overall, but it did decline. So when you look at data from us, you wanna look at, does it go up or down, but you also wanna look at the absolute level. So these two dimensions here are supervisor dimensions. And they're up in the 90s, right? So what this tells me is that even during the pandemic, these supervisors were holding steady, right? There was some diminution of the sense-giving aspect of telling their crews why they were doing those things as the pandemic got worse, but it held pretty steady. But leadership has a road to travel. They're down in the 50 and 60s, right? In this particular sample. So there's a big gap between perceptions of management and supervisors here. And we can see that leadership communication also took a hit. So these are things, when people have a bad management commitment score, we can start to add things into FOCUS like leadership communication and participation in decision making, which help us analyze why that score isn't as high as it could be. And it gives us a path to follow and some action steps. But the thing I want to point out is this is the COVID cases during that period of time, the gray line. Anybody want to do some interpretation on this for me? What is the story you would tell me with this graph?
Cases went up, communication went down.
Yep, is it a one-to-one relationship? No, not at all, because it would have the same slope, right? And so this is a pretty extraordinary increase, right? But this diminution here is not that deep of a slope, right? That's a good thing, right? It's not like if your case count goes up, everything goes to the shit. I'm sorry, this is being recorded. I can't get fired, right? I can't get fired. So it's not a one-to-one, which is good. That means that there's resilience, that there's experience in your fire departments. Yes, when you are faced with something like this, leadership is going to be challenged. And in my opinion, it's leadership that really took the hit during the pandemic, because in a lot of cities I work with, the rank and file were still on their regular shift, but the leadership was at the OEM in a trailer for months and months and months. They never really got a break. So, but still during that time, we know that in the next thing that happens, the next pandemic, the next natural disaster, that leadership communication at a baseline is low. And during an event that challenges us over time, it could drop, right? So we know that we should pay attention to that. Does that make sense? Everybody doing okay? Okay. So I'm going to break this down a little bit. So you know, remember on Josh's FOCUS report, right? We broke things down by fire and EMS. And again, we've got a pandemic going on, so my hypothesis is that EMS is going to take the brunt. So solid lines are fire, dotted lines are EMS. Sarah, in these 6 months, what do you see happening here? Fire is the top line and EMS is the dotted line. Yep, and I'm sorry, this is engagement. So this is being vigorous, absorbed, dedicated to your work, like time flies when I'm on the job, right? So fire held steady or possibly even increased in this sample, right? But EMS had a decline. That EMS decline in engagement was statistically significant, right? The fire wasn't, right? So now, again, solid lines are fire, dotted lines are EMS. Now we're looking at those two different aspects of burnout, emotional exhaustion and depersonalization. So Josh, what do you think about, what can you tell me about what you're seeing here in these data? Mm-hmm. Mm-hmm. Yep, and then statistics tell us, which of these is significant and et cetera, et cetera. And then the other thing you want to look at is the direction of the line, whether it's increasing or decreasing, but the difference, right? Look at this gap between EMS and fire, right? It sustains. As a geek, it's exciting to see because it's what we would expect. I mean, it's not what you want to see on the operations side, but that these are the same people answering these questions, and we're seeing this sustained gap between the perceptions, the burnout levels you're feeling on these different aspects of your work. So we look at that all together, and we start to tell a story about EMS engagement, EMS burnout, and what's happening during the pandemic. The really interesting thing here, I'm showing you data from big metros, so they are career departments, so not a lot of turnover. So we measured stress, which held steady, and we measured intention to leave the profession, which had our largest significant increase of any metric in this sample for people who are not going to leave, but it is how they're feeling, right? I've been looking for work outside of the fire service. That's the question. Again, it might just be a coping mechanism, but a really interesting piece of data. So we're now going to include this in focus because we think it's important. So, and then these are our anxiety and depression scores. So anxiety, it's interesting. Again, this is only the first 6 months of the pandemic. Anxiety is in blue. So it started high and then kind of leveled out. And depression started low and then increased. Right? So these are things we're continuing to track, right? But these metrics have been so useful to the fire departments who participated, they are now going to be on the focus assessment. So you just have more deep data on focus about leadership communication, decision-making, governance, and more about mental health outcomes. So the states, the fire departments that participated in this rapid COVID-19 mental health assessment have given us new information to include on your focus assessment, and you will have that in Focus 3.0. So I share all of these data to just share with you what we know about the environment that fire-based EMS is working in and what we know about the data so far, right? So we are seeing an impact of the pandemic on the health and well-being of firefighters. We know from the national data that the resource demands on fire-based EMS responders are out of control. So that's going to have an impact. So we were awarded a Fema grant, a research and development grant, to do something about stress and violence to fire-based EMS responders. It's called SAVOR. And it just ended in February of last year. And so we have 2 products from the research. And what we did is when you are in the field, how many people do EMS or a paramedic? Okay, so when you're managing an asthma patient or doing an intubation or something like that, you usually have a checklist, right? So we have checklists in healthcare all the time for providers to make sure you don't kill a patient, right? We are very concerned about patient safety and making sure we do the right thing for the patient. Who has your back? Right? That's where I come in. I am a certified professional in patient safety. I have a board certification in patient safety. I know all about patient safety. But I also was trained by NIOSH when I got my PhD in occupational injury epidemiology. And what I learned is that when the safety climate of an organization is bad, not only do the patients suffer high rates of medical errors, but the nurses get injured too, right? So I have been very, very focused on the occupational injury side of safety climate for a long time. So checklists are always about preventing the provider from hurting the patient. And I thought, who has their back? What about a checklist at the organizational level for the responder? Big smiles, everyone, right? No one ever thinks this way, right? An organizational checklist. So we went through all this industrial literature that USFA and IAFF paid us to do. We built this checklist and we brought together 50 thought leaders in fire and EMS. Our 3 departments were San Diego, Dallas, and Philadelphia. We had everyone from the chief through a dispatcher from those departments. We had people from NIOSH, from OSHA, from all of the EMS management organizations. We had EMS physicians. We had Ben and Kelly, right, who I showed you at the beginning, right, who gave testimony to their assault injuries and the psychological ramifications. We had some old retired guys. We had everyone there. And they took this draft checklist, and over 2 days, they made it into a final checklist. And I want to describe it a little bit, but I want to be mindful of time. So this checklist was based on the structure of an EMS run. So we know this area that's on the call, we know that's an EMS run. The tones go off, you get dispatched somewhere, you're going to the event, you arrive on the scene, you do your patient care, you transport, and then you're done. But what we didn't see in the literature was anything about the organizational policies and practices that should be in place before the tones go off and you get sent somewhere, or what you do when people get they have problems, injuries and psychological injuries on the job, and how you help them recover. Totally missing in the literature. Your industry or otherwise. Nobody had this, so we added it in. So we developed a checklist, and I won't go through all of it, you can read about it in the paper, for each of these phases. And in each phase, we asked 2 questions of this group. Is there a policy? And are you training on that policy? So we developed these checklist items for each phase, and then the other thing that we did is, so these are things that the fire department and the union have to do to have the back of the responder. But we also did something very innovative. When I am a surgeon and I am about to cut into this person to remove their cancer, I do something called a timeout. Anybody know what that is? Before I do that, I ask the surgical team, who is this patient? What procedure are we doing? What leg are we amputating? And does anybody have any concerns before we begin? It's called a timeout. And it's a great way to make sure, and it's caught a lot of wrong site surgeries and wrong patient surgeries. Whoops, it happens. So these pause points were built into checklists to give autonomy and authority to the worker, for them to say, hold on, I need a moment, I know what's going on here, and I need everything to stop so I can prevent an error from happening. So here's the pause points for the providers in the field. There's only 6 of them. The organization has 185 things to know, but the individual responder has 6, and they are empowering. The first one is, if you have knowledge that this is a previously known violent location, request and wait for law enforcement backup before you go in, right? That knowledge exists. It may exist in your CAD system, it may exist in your police dispatch system, that you rolled up to this place and stuff has happened before. Before exiting the ambulance, are all of the resources you need in place to safely begin patient care? Maybe you need a piece to show up with 4 guys on the back because this is a body lying in the street and you need some protection. Maybe you need police. But before you step out, do you have everything you need? Before transport, does your patient require restraint, whether chemical or physical, and have they been checked for weapons? So often, the data that I showed you about assaults happening in the back of the box are after the doors are closed and that person has a box cutter or takes your scissors and stabs you with them, right? Patting a patient down. And after it's over, before you tell dispatch you're ready to return to service, are you mentally and physically ready? Now in Philly, our medics don't eat, sleep, or pee, and they're under a lot of pressure to go back in service because we don't have enough medics. But then we're doing the work on their backs. And so we need to change the paradigm. And this is giving them the ability to say to dispatch, we just had 2 dead kids, we need to go back to quarters, you need to send somebody else, we're out of service. Or I need to go back to quarters and just talk to some folks, or I need to go on a run right away because I don't want to deal with this right now. Whatever it is, giving autonomy to the workers to say what they need, because everybody deals with stress differently, and fire departments need to have policies that understand that. It's a hard one. If you've experienced verbal or physical violence, have you utilized the appropriate method for reporting? Because you can't manage what you don't measure. And if I go to city council and say I need 5 more ambulances because we have too many runs and people are getting assaulted, and they say, well, where's the numbers? And I say, well, I just made it up. People have to report or you don't have good data to stand on. And then the 5th one is seeking long-term physical and mental health resources so that you feel ready to return to service. So this is revolutionary, to be able to give your EMTs, paramedics, and cross-trained firefighters the ability to slow things down. But it is a real need for them because we can't control the volume, but we can control how they decide when they work and how they work. That is something at our disposal. So people loved the checklist. It was a great thing. People were saying it's long overdue. This is all labor management, et cetera. And after we developed the checklist, we only brought the 3 fire departments that were going to implement these policies back. So Philly, San Diego, and Dallas. And we brought them back a month before all the states shut down. And we took those 174 checklist items and we reduced them into 8 model policies. And so that paper is just about to come out. So the checklist paper is available to you. You can read the whole thing. But what the firefighters did is they looked at all of these items and said, what is feasible? Meaning, what can we do in the next 3 to 6 months? And so 80 of those items were considered to be feasible, and they went into 8 policies that are adopted as a compendium into your policy manual. And I just want to show you what those are. And this is an example of the checklist in a reduced form. Your mission statement. The goal of this policy is to establish an organization-driven focus on the health and safety of members as they respond to calls, including both EMS workers and patients. Because there's a potential for violence on every call, the policies contained here focus on ensuring that the organization has defined their role and espouse values around keeping their workers safe. The policy statements listed would require a clear statement about the importance of safety, health, well-being, and aftercare for members, as well as minimize concerns related to rank, power, and distribution of available services. I'm reading the words of firefighters who wrote these policies and what the goal of these policies are. So does your mission statement say something about we value EMS at the same level as fire suppression? Because I have been told by EMTs that we are the red-headed stepchildren of the fire service. We are the second-class citizens. But I've already told you it's 60 to 90% of the work. That's your culture, right? But you can start to change that by having your mission statement be very clear about how you feel about EMS. Another option is instead of a complaint card in the back of the ambulance, you might put a card that says it's a felony to assault a first responder in the state of X, as opposed to if you have a problem with the service today, call 1-800. It sends a very strong message to the worker about who's got their back. Right? So this is all in the pre-event phase. This is stuff that you do in policy land, that when someone joins your fire department, this is what they see. Wow, I'm here as a single role paramedic, and they give a shit about me. Very, very different than the history that you might have been raised in when you came onto your fire department. Painful? Yes. Revolutionary? Sure. But this is what fire departments are doing. The second policy is defining violence, because everybody had a different definition for this. So there are definitions in the checklist from the World Health Organization and the CDC about what workplace violence is, and it branches from being assaulted by a patient to verbally threatened, which is 90% of the violence you experience, to having your stuff stolen from the back of the ambulance or the fire truck, right? Property damage, threats to your family, these things are all workplace violence. So making sure people understand that physical violence is not the only type of violence there is. During the SAVER project, we used Emerge, a locked down patient safety reporting system, and in these 3 sites, verbal violence was the most common experienced, and it was the cause of most of the health complaints, the stress health complaints. So having a definition. And then dealing with dispatch, right, which was a huge issue. And making sure that information is flowing from the caller through the dispatcher to the person in the field so that they know what they're walking into. And previous data from CAD or the police department or whomever is available to those responders so they know if they should stand down and wait before they walk into something that last week another crew experienced. So there's all kinds of things here, and pause points are integrated throughout these. Assessment of communication and scene conditions so that people know what's going on, and having common language for everyone to communicate when there's trouble. So we are currently working with the IAFF on this EMS survival course. And one of the things that you're probably going to argue with me about on the break, as I've studied the fire service, I'm wondering why on EMS, when we're getting assaulted, we don't call a mayday. Everybody knows what a mayday is. Why are we saying cover now, cover now? Why are we saying different code numbers? Why are we saying assist, assist? Why don't we have a common language for this? Sir?
Well, we were just talking, and I'm like, well, in a mayday situation, we're asking for help to resolve it, right?
Yep.
Most of the EMS calls, or all the EMS calls that I've been on where me or my crew have been attacked, we have fixed the problem. I mean, the attack stops, and we fix that, and then we get cops there, and they go to jail.
Right.
So, I guess help me understand what you're asking.
Sure. Well, look at Ben and Kelly. Right? They didn't resolve the assault. So, and then Ben, if I have the video, just didn't have time to show it all, but Ben's yelling, cover now, cover now, cover now, right? There were 12 guys there, most of them armed. And nobody had this under control. So again, resources could have been set. In Kelly's case, they did call for an assist. They used whatever code word they use in Detroit, and nobody came. They were battling this guy for 20 minutes. The truck was filled with their blood. They ended up driving themselves to the hospital. And her partner doesn't work anymore. Like he's in vapor. So there are times where someone assaults you, you're able to control it. So we're doing two different types of like Mayday as we're developing the course for the IAFF, which will be available to everyone because it's FEMA funded. So it's available to career volunteer districts, whatever. But we're looking at the when you've solved the problem kind of situation versus when the problem is not going to get solved by you. And training, and again, when there's a Mayday, everybody knows what to do, right? Why don't we treat EMS the same way? Again, we can argue about it over bourbon, for sure, you're buying, but these are the kinds of things that as a scientist I'm asking, like why are we coming up with different words for this? And whatever the word is, let's make it a standard so that everybody knows what to do and what's happening then in that moment. So I have run with fire departments and I have walked into homes and our flank is totally exposed and then someone comes around out of the dark and I'm like, what the hell is happening here, right? So it happens. People aren't prepared for it. So there's other, I won't go too into it, but we need to have standard operating procedures during patient care so that we are able to provide direction and protect responders. And this is one that we grappled with as a group for a long time, but your readiness to return to service after a run, you've all experienced trauma. And you've all experienced it differently. And some things bother you because you have a 2-year-old at home, or you have an 80-year-old at home, or you were in the military, or whatever. You don't know how people are going to respond and what they need. This assessing readiness to return to service is encoded in policy that the responder gets to decide what they need, and the department and dispatch will respect it and support it. You are concerned about suicide. You are asking me all the time about PTSD. If you don't give people the option to provide their own release, I cannot help you solve that problem. That's the end of the story. You have to give them autonomy. You can't say, I don't care if you just went to a 4-car crash and 2 people dead on 95. We don't have enough ambulances. We need you back in service. So you're doing the work on their back at that point. You've got to have other outlets to deal with the fact that you're not staffed appropriately. Reporting of violence, again, I think I've covered that. If we don't have data, we don't have a leg to stand on. And then this mental and physical health support was deemed very important. And we wrote, so we have, I'm not showing you it all, but we have policies written. So there's like 8 different levels to this particular policy. It's all written out in model language, right? So that you could take these policies and implement them into your department and put them in local parlance. So they're what the fire service agreed was important, but they recognized that local control and modification are necessary. So they're model policies. And you can expect far more work like this from the First Center, where we're developing policy for you, you can modify it to your local, and then we can evaluate how it's working. And so already, the Philadelphia Fire Department put out OP 42, which is a model policy for what company officers should do when a member has been assaulted. Prior to involvement in SAVER, they had nothing. And that's where that, somebody should, when I go to court, that person's there all dolled up and no one's with me. But if somebody falls through a roof, you've got 8 people showing up at the hospital, including the mayor, right? So this helps set a path to follow. This is an SOP as opposed to a policy, so it has tone about we care, we've got you, we're going to be with you through this. It's a big change. Dallas built a resiliency program from the data that they had from the SAVER project. And they've had a huge assault issue. I've talked about the IAFF training curriculum we're developing. So that's going to be an online course like the Fire Ground Survival course, and we're building a practical course with things like evasive self-defense and de-escalation techniques. So there'll be a practicum in addition to the online curriculum. And this is my goal. So I'm going to retire in 12 years. And so my goal before I retire is to move the needle on this. I can tell you by NFPA how many fire plugs we should have and where they should be, and how many fire stations and where they should be. I cannot tell you how many EMTs we should have per 100,000 population or 1,000 runs. And that is wrong, because it doesn't give fire department leadership anything to stand on when they're asking for resources. We've got to have some sort of standards. So that's my goal. If I can get that done, I can retire early, which means I'll be back here fly fishing, which is great, because I already have an invitation for Helena, so that's great. So SAVER has a lot of publications. These are all really groovy to read. None of them are boring. You don't need to take these as sleep aids. These are all about stress and violence. And again, the words of your brothers and sisters and what they have told us. What you tell us is what we do, right? So I really encourage you to read about these stories. And we hear from folks all the time about how these stories, they're like, yep, same thing. I can't tell you how much I hear. I have been spit on, pissed on, shit on. Like, I hear it from every single firefighter I meet. So, sorry I rambled a little bit too long. We're at 11:30, but we have good data on how the work is affecting the mental health. From your focus assessment and also from the rapid assessment, we now have a deeper focus instrument for you that is going to be launched. These policies are available for you now if you want to implement them. If you want to implement them, please call me, because I would like to evaluate how it makes an impact on your members' mental health. Because if we don't measure it, we can't send it out to the rest of the fire service saying these policies are making a difference. So there's more interventions that we can talk about specific to burnout. But again, as a public health scientist, I'm more interested in solving problems before people get exposed to hazards than treating them once they are. There are plenty of other people and resources out there once you have a mental health diagnosis, a cancer diagnosis, a heart disease diagnosis. But for us in the prevention space, I want the firefighter, the paramedic, the EMT who comes to save my life, which I've had done twice, to be ready and rested and recovered. I want them to see me. I want them to be able to diagnose my condition. But if we're doing work on their backs, they might miss something, right? They might miss me. So that's why we do what we do. So, questions, comments? You're welcome. So I think, that's it. So thank you so much. All these slides, Michael will get all these slides, so they're all for you. This is your work and the work of your colleagues, so.